All right. Thank you everybody so much for joining us today. Today's webinar, we will be talking about waves of behavioral therapy. And your presenters today are Lauren Martone and Hunter King. Lauren is a first-year doctoral student in school psychology here at the University of Utah. And she also works as a graduate assistant in the U-TTEC lab. Hunter is a third-year doctoral student studying school psychology, also here at the University of Utah, and he also works, at the U-TTEC lab as a graduate assistant. A couple things before we get started really quick. From 2 to 2:45, we will be having the talk, and we will be having a question and answer session, 15 minutes at the end. So if you have any questions you would like to submit for the session, please feel free to drop that in the chat box. Please remember to mute your sound, and if you are comfortable, you are more than welcome to turn on your video. I'm going to turn it over to Lauren and Hunter.
Thank you, Annie, for that warm introduction. I greatly appreciate that. Real quick, let me share my screen so everybody can see this PowerPoint real quick. All right, thumbs up. Is this working? Okay, good to hear. So,
Hunter, before you get started, if you flip, there's this says swap displays. Right now we see the presenter view. On the top left, there's like two little arrows that look like they're spinning. Cool. Now you're good.
All right. Wow. I didn't know that was a thing. Thanks for that suggestion. So yes, we're going to be talking about waves of behavior therapy during this webinar, which is a topic that some of y'all may have never heard about, whereas some of y'all may be more familiar with this. When I refer to waves of behavior therapy, you may be more familiar with terms like cognitive behavior therapy, exposure, acceptance and commitment therapy, but you may be less aware of they actually fall within these sort of waves of behavior therapy where each one sort of emanated out of the preceding one. And we actually have three waves of behavior therapy, and we're currently in our third. And so this webinar is really going to touch on the main differences between the three waves of therapies, the context surrounding each shift. So why did we go from wave 1 to wave 2, and wave 2 and now into our current third wave? And then we're going to talk a little bit about the three most commonly researched and really, I think, most practically relevant third wave therapies, which is dialectical behavior therapy, DBT, acceptance and commitment therapy, ACT, and mindfulness-based cognitive therapy, MBCT. I'm going to try to reuse these acronyms because if we don't, this will just go on and on and on. Pretty technical terms there. And then we're going to end, I guess like the last quarter or so, Lauren's going to touch on the practical differences. So what does a second wave therapy and a third wave therapy look like, comparing and contrasting them when treating generalized anxiety disorder? So let's go ahead and get right into it. So this is to provide you with a reference point on what I mean by waves of behavior therapy, with each one on this PowerPoint indicated in its own color. So the first wave around the 1940s, you think of B.F. Skinner, Thorndike law of effect, really just a lot of reinforcement, changing people's environments in order to either increase or decrease a particular behavior. Then the cognitive revolution came around the 1960s, and now we have a way to conceptualize how thoughts and feelings might be contributing to somebody's clinical issue. And then now we have our third wave, which you think of ACT, DBT, acceptance, sort of these Eastern ideologies bridging with Western behavioral practices. Now, the biggest difference here regards these brackets in the top part where you see first order change and second order change. First order change relates to how a therapist, or I guess first order or second order change refers to how a therapist conceptualizes and treats a client's concerns. First and second wave fall under first order change, which looking at, they see the form or frequency or content of our thoughts or behaviors as problematic. And then in order for somebody to get better, we need to target that behavior or change that thought in order for them to benefit from therapy. So it looks at changing how often a behavior is occurring or how we think about something. It views them as problematic. Second order change takes a very different approach. Rather than seeing these behaviors as problematic, it really looks at the function of that behavior or the purpose. What is somebody getting out of this behavior? Because a behavior could look inappropriate or unhelpful, but it might work well for somebody in certain contexts. So there's this big idea of looking at the context in which a behavior occurs, as opposed to just looking at specifically how often it occurs or what it looks like. These next couple slides will hopefully clarify what I mean. Take a look at this chair. The form of this chair. If I probably would never buy this chair, I would throw it away. I would see it as really not having any purpose. So the form of it, okay? But think about this. Is there any way or any context where this actually might be effective or useful? Because it doesn't look like it. Well, I don't know. It tells me like this could be a good practical joke sometimes. Might be in an art exhibition. You know, beauty's in the eye of the beholder. Who knows? Somebody could buy this for $100,000 one day. You never know. Or a learning experiment where it might demonstrate a design flaw in a carpentry class. So when we're in third wave therapies, which we'll get into more in here a little bit, we're really looking at, okay, it might look unhelpful, but it might be helpful to look in which situations in which this might work well for somebody. So just because it's broken doesn't mean that it needs to be thrown out or changed, because it actually might serve a really purposeful use in different contexts. How about a clinical example? Somebody might have the thought, if I don't practice every day, I'm gonna fail at this. I don't know, I may or may not have had that thought preparing for this webinar. Graduate students probably have this from time to time, or maybe people who just started a career really had this on the forefront of their mind. I have to do well, I have to practice, I can't mess up. Well, gosh, the form of this thought or the content, it sounds pretty negative. Think about all the negative outcomes that could come from this. It might imbalance your work-life balance and personal care. Gosh, tons of anxiety possibly. Or maybe you're foregoing your relationships. Are there any situations where you can think that this thought might function well for somebody? You could get increased pay by practicing things over and over again to where it's very polished and you're not making mistakes. This could lead you to get promotions, job status, or positive feedback from your employer or supervisor or from your colleagues. This is what I mean by first order versus second order change. Second order change in third wave therapies really looks at the context of all these behaviors and what we're doing, as opposed to just throwing them out or trying to change them. They might actually be helpful in certain situations. So it might be good to keep them in case they might be workable in different contexts. So this is what I mean. Hopefully that provides some context there or a reference point on what I mean by changing something based on form or frequency versus its function and how it works for somebody in a certain situation. So here's first wave behavior therapy, which came about in the 1940s as really a replacement for psychodynamic theory. So when I say psychodynamic, you think Sigmund Freud, you think of dream analysis, you think of the subconscious, very subjective types of treatment strategies, right? And it worked well for some, but maybe not for others. And because it was subjective and we couldn't really reliably trace this strategy to this outcome for different types of populations, psychology and the field of just science in general felt we need a more empirical and objective way of behavior therapy, one that we can establish as an evidence base, because we can reliably say, when I do this with this client, this outcome comes about. So here we have very, very radically behavioral treatments. Contingency management is when you provide somebody money for remaining abstinent for substance abuse. Exposure is when you have somebody purposefully expose themselves to something that's anxiety provoking so that they become habituated to it and their arousal will decrease the next time that they're exposed to that stimulus. So you're getting this idea, hopefully, that this is first order change, because for contingency management, we're trying to decrease substance use For exposure, we're trying to decrease physiological arousal. It sees these behaviors as problematic based on how frequent they are or what they look like. So this is first wave behavior therapy, 1940s, 1950s. Punishment, reinforcement, that's really the basis of what this looks like. So something happened around the 1960s. The cognitive revolution came about, and this helped us to understand, like, there were certain things going on that led us to believe maybe a new wave of behavior therapy was needed. The first part of this is after World War II, veterans came back from war with really debilitating post-traumatic stress disorder and all of the symptoms that come along with that. It was really rough. But at the time, all we had were first-order behavior therapy treatments, specifically exposure. So a therapist would have a veteran sit down and purposefully try to reimagine that traumatic experience and go over it in their mind over and over again so that they wouldn't have that thought as often, or their heart rate wouldn't go up as much next time they thought about it. And that's what happened. It was effective, but it was also ineffective. Yes, it decreased their physiological arousal. Yes, it decreased the number of times they were reminded about their traumatic experience, but it was less effective for their avoidance behaviors. When I mean avoidance behaviors, think of this. Let's say you're socially anxious and you're invited to a party. You sit on your couch and you're thinking, gosh, I'm going to be such a loser there. I don't have anything cool to say. I don't know anybody. What's going on there? You're thinking a lot. There's a lot of thoughts going on that's preventing you from going somewhere. There was no account for thoughts and feelings at this time because all we had was exposure treatment for this population during our first wave behavior therapy. Moreover, a lot of veterans saw this as very unpleasant and scary. All I have to do is just constantly expose myself to this trauma. Doesn't seem very good. So therapists increasingly realized the importance of a functional account of thoughts and feelings and how we can use this in a clinical setting. The computer metaphor is what allowed this to happen. Scientists figured out that there is sort of a parallel between how a computer versus how a human brain inputs information, stores it, and outputs information. It was very mechanistic. Take, for example, a computer. If it breaks, what happens? When you take it to a mechanic or something, they find the faulty piece and they change it or they replace it. That was the basis for how cognitive therapy came about. In second wave behavior therapies, we're now in cognitive and cognitive behavior therapy. Still in first order change, okay? This definition up here by Aaron Beck really contextualizes what I mean by first order change. I'm gonna read this definition and I want you to listen to some of the words I say and how that might relate to first order change. Techniques designed to modify the dysfunctional beliefs and faulty information processing characteristic of each disorder. So modify something because it's perceived as problematic. Dysfunctional, well, that sounds like something's a problem too. So does the word faulty. So we're still in this first order change, but we're in second wave therapy now, okay? So we see the content of our thoughts, how we think about something, how we're processing information as problematic. And we need to change that to a more healthy way of thinking or consider other information into our thoughts as well. It also looks like behaving too often in a, wanting to decrease our behavior or increase it because it's perceived as problematic or really getting in the way of our life. So second wave, again, we're in cognitive therapy. We now have a way to conceptualize how thoughts and feelings are playing a role in a client's presenting concern. This was really, really big because, I mean, think about how important language is. It's really hard to disregard that in a clinical setting, given that we ruminate on the past, we plan for the future, we compare ourselves to others. The computer metaphor was really helpful in this regard for second wave therapies. Now, just a review here. What are the similarities and differences between first and second wave? Remember, first wave was radically behavioral. Second wave is now we have sort of a cognitive therapy that we're able to address as well. Well, they both still fall under first order change, which again looks at changing what a behavior or a thought looks like, or changing how often you have a particular thought or engage in a particular behavior. So changing them, they see them as problematic. Well, what's the difference? Sort of just mentioned it a little bit ago. First wave behavior therapies did not have a way to really see how language and cognition and feelings were playing a role in somebody's clinical issue. Second wave did, because of the cognitive revolution and because of the computer metaphor that really put a parallel to how a computer versus a human brain takes in information, stores it, and outputs it. So this is my favorite slide because this tells us that there was something going on around the 1970s, 1980s that led us to shift from second wave therapies now to third wave therapies. And we are currently in our third wave right now. But this is interesting because cognitive therapy, cognitive behavior therapy has a very strong evidence base. Lots of randomized control trials continue to show it's really effective for a lot of populations. So why the heck would we move out of that into a different one? Here are some of the 4 most common reasons. A component analysis. A component analysis is when there's an emerging therapy and it's been shown to be pretty effective in certain populations. We want to scrutinize that therapy and we want to see under which aspects of that therapy, what strategies, are shown to be the most effective for treating this particular client or this particular symptom. So they, had these very rigorous studies to do this. And so what they did was they would compare cognitive therapy and then behavior therapy, look at their component analysis and see which one showed to be more effective. Interestingly, there were a number of studies that came out that showed that there was no additive benefit compared to behavior therapy. So adding this, layering on this cognitive piece was shown to really have no difference in terms of treatment outcomes in a number of studies. So that suggests to me that therapy, when you add a cognitive component on there, therapy is now a little bit longer, but you're getting the same outcome as a shorter behavior therapy. So that's important to know. And now therapy outcome. The changes occurred before the cognitive interventions were even implemented in certain studies. It's kind of interesting. And I don't have any empirical information to support why that may have occurred, but I kind of have an idea maybe. So people who may be who are very depressed forego, getting up and actually putting their boots on and going and seeing a therapist. It's not until maybe they call the therapist and schedule something that they feel like they're doing something better for themselves. They might get a little bit more energy and they're starting to make change, finally, right? Therapy hasn't happened yet, but they feel good about themselves for initiating it. It also could be during the first couple of sessions of therapy is usually a rapport building where you're getting to know the therapist, they're validating your concerns, you're getting stuff off your chest. That could also be cathartic too. So those are just 2 examples that I could kind of see as potentially happening based on some of the clients that I've worked with as well. It's too mechanistic. Cognitive therapy was too mechanistic. The computer metaphor, think about it. Do you think that the way that we think is really just like a computer where we can change one thought and then you won't have any other thoughts like that again? Probably not. Imagine going down and you're going to Halloween, right? And you're trick-or-treating and you see an orange pumpkin. Well, that thought might bring up another related thought about maybe trick-or-treating when you were younger, maybe going to see a scary movie. It's like a web of thoughts that are related to one another. So trying to find this one problematic thought and change it probably isn't going to address the related thoughts that could come up as well. So it was too mechanistic. It really does not account for the complexities of human language and how we think about the world and how we construct the world. Our brains are really not like computers. Maybe in some senses and how certain things might work, but think about how you think on a daily basis. It's much more complex, I believe. So there's this idea of looking at the context in which we think or behave, as opposed to just what it looks like or how often we're doing something, because it might be that certain thoughts might be more helpful or less helpful in certain contexts. So eliminating them or changing them might not be the best way to go about it. Now, less federal funding. This was the one piece where I only found one source for this, written by Stephen Hayes himself. So second wave therapies, cognitive therapies, the effect sizes sort of stagnated. They weren't really on this increasing trend anymore. They were still, you know, moderate to large for certain clinical populations. They sort of plateaued. And there's also the Federal Drug Administration realized that even pharmacological therapies were like an SSRI for depression or something along those lines was having an effect greater than what it was intended for. Yeah, it might decrease depressive symptoms, but there was also a positive effect in other areas of the person's life. So because it was too mechanistic, second wave focused on very narrow symptoms and populations. The Federal Drug Administration and the grant funders that fund these large trial, randomized control trials for emerging therapies wanted a therapy that was maybe a little bit more transdiagnostic. One that touched not just on one area of somebody's life, but multiple areas of their life, okay? This is a big piece of third wave therapy. Just to reiterate, second wave therapy is really focused on decreasing this behavior or increasing this or changing a thought. The FDA and other agencies that funded these types of studies were like, oh, we need something that cuts across multiple areas of somebody's life because life is complex. It's not just one symptom, it's a host of symptoms. So now we're in the third wave of therapies, the 1980s. So I included the 4 most commonly referenced ones in the literature: MBCT, ACT, DBT, and FAP. We're not going to be discussing FAP because it's received less amount of attention. So we're going to be focusing on those other 3. So we are now back to this sort of, I wouldn't say radical behavioral treatments, but it's definitely much more behavioral than the cognitive component. And we're including things like humanism, mindfulness, acceptance, constructivism. Humanism just looks at the person as a whole in their life. Constructivism looks at how people construct their reality based on how they intake information, how they think about it, okay, and how that resonates with them. So the big idea now here is second order change. We're looking at the way certain behaviors or thoughts may work well for somebody versus another person. We're very non-judgmental. We don't see them necessarily as problematic. We see them as workable in some situations and less workable in other situations. It's how we behave. It's an ongoing act and process. We have to consider context, not just what something looks like or how often it occurs. So the similarities: second wave cognitive therapy, third wave ACT, DBT. What's the similarities? Well, they definitely emphasize the importance of language and cognition. That's great. But how do they differ? First order change versus second order change. So for second wave cognitive therapy was looking at changing the form and frequency of behaviors, versus third wave is now looking at the function or what people get out of this particular behavior in particular contexts. Much more holistic. So let's talk about dialectical behavior therapy. Oh, I said I would just use acronyms. DBT. So we talk about DBT a lot in schools. It's very helpful for emotional dysregulation, helping people to realize patterns of how they feel in certain situations and then effective coping mechanisms. But what I hear less is what dialectics is. I feel like this is something that's really important to note because it's really the basis of DBT. Dialectical thinking refers to the ability to see issues from multiple perspectives as opposed to this very black and white type of thinking. And so I provide an example here. So there's a teacher and it just has a very disruptive classroom. And they might think, like given the teacher's background and teaching and experiences and tolerance for disruption and other contexts, they're doing the best that they can. At the same time, they might wish that they had more resources so they didn't get so frustrated. So the dialectic here is, I'm doing the best that I can and I want to do better, okay? 2 different beliefs where you can find a middle ground because of the word and. If you were to use the word but, it changes things a lot. This is how powerful language is. If you were to say, I'm doing the best that I can, but I want to do better, you might as well delete the first part of that dialectic. Now you only have one option, to do better. The whole point of DBT is to get people to realize that problems afford opportunities too, and that if we can change the way that we think from using absolute words to more flexible, open types of terms in our language, such as either or to both and, it opens up various options for problem solving, as opposed to really pigeonholing ourselves into this idea things have to be this way or they have to be that way. Well, where did this come about? This therapy in particular came about to treat borderline personality disorder in individuals who had lots of suicidal ideation and attempts as well. But remember, and this came about in the second wave cognitive therapy, when we only had we viewed behaviors as problematic and they need to be changed. Well, this particular population who has very strong emotions that sort of wax and wane a lot throughout the day, they viewed this as a very critical way to go to therapy, saying, hey, you need to change the way that you think in order to have a more appropriate, for therapy to be effective, essentially. And so they found this to be very unhelpful. So telling somebody who has these tendencies of emotional dysregulation, you should change your mind about this, or are you considering this? Maybe you should do this more, really gets at this idea that they're doing something wrong and then they need to change it. So the key here was to use acceptance and change-based strategies. So third wave therapy, we've talked about how we don't look at seeing behaviors, the form or frequency as problematic. Sometimes it does help, especially with suicidal behaviors as well. So the way that you might go about this is to absolutely validate this client's concerns, but at the same time, in a very non-judgmental way, discuss opposing views to help them consider that this behavior might be a little dysfunctional and it might benefit them to change this behavior. So we validate primary emotions as opposed to secondary emotions. Primary is, the initial emotion you feel. Secondary emotions are the emotions that come up after you've had some time to think, all right? They're not the exact ones that you came with. You use a lot of metaphors in DBT to promote flexible thinking as well. So now, mindfulness-based cognitive therapy. Read the title here, cognitive therapy, mindfulness-based. It sounds just like we were talking about in second wave. So how the heck does this even come to be a third wave therapy? It's the mindfulness piece, and I'll show you what happens. So here on the right side of this PowerPoint is a diagram that shows what depression relapse looks like. At the beginning, you have a negative thinking episode, you go to therapy, and in therapy, you learn to stand back and evaluate the content of your thoughts. This is second wave therapy, all right, cognitive, where we're looking at changing things. When you step back and you evaluate the accuracy of your thoughts, or if you need to change it, what you're doing there is you're actually engaging to a degree in a third wave strategy called diffusion, where you're distancing yourself from your thoughts. And when you do that over and over again, you realize that your thoughts have very little control over your behavior. But at the time, this took a little bit of time for scientists to realize this. So in second wave cognitive therapy, you would evaluate your thoughts, you would change your thoughts, and then you would try and use that new thought more often the next time you had an unpleasant experience, or once that depression starts to creep up again. So how does this a third wave therapy? Well, we kept the observing our thoughts piece, but we left it at that. We didn't want to focus on changing anything. We now want to step back and observe our thoughts non-judgmentally. We're not seeing them as problematic. We want to just see that these are words with no literal meaning that will pass as time goes on, just like a wave. Waves of behavior therapy, right? So there's this focus on awareness of and the relationship to these thoughts, as opposed to just seeing them as problematic and letting these words that are in our heads really control our behavior. It happens a lot, and I will admit it happens to me, and I try to practice non-judgmental observing of my thoughts too. It's called cognitive diffusion, and Lauren is probably going to talk a little bit more about that. Sorry, I should have clicked that arrow a little bit earlier. And so I'm going to turn it over to Lauren now, who's going to talk about acceptance and commitment therapy, which is one of the most popular third wave therapies.
Yeah, thanks, Hunter. My computer kind of restarted there in the middle of Hunter's talking. We'll pray it won't happen again, but I'm sure Hunter will have my back just in case, but fingers crossed here. So the final third wave behavior therapy we'll be talking about is acceptance and commitment therapy. And the key model of ACT is called the hexaflex. It can be seen on the right hand of the slide. And at the core of ACT is psychological flexibility, which for any individual means being open to the present, doing what matters in the present moment. And then surrounding that core are 6 processes that work together to promote psychological flexibility. And out of the 6, there are a few that are really highlights because they're specific to ACT. The first is the idea that behavior should be in accordance with the individual's core values. So a big part of therapy is identification of those values in a variety of domains, such as health, family, or religion. And these aren't behavioral goals like I want to own a house. They're more like qualities we want to embody, like I want to be independent, which might hopefully result in me owning a house one day, but it's something separate that I can kind of incorporate into all of my behaviors. And then the second highlight is that a life without pain and suffering just doesn't exist. This idea is really central to ACT because ACT proposes that we often amplify our own suffering by trying to suppress or control it. Pain and suffering, I mean, they can be organic and medical and come from real current circumstances, and we're allowed to experience those things. We don't need to control or suppress it. Rather, those behaviors can often worsen our suffering. So these 2 points about values and about suffering are really critical to understanding what ACT is really about and differentiating it from some other therapies. So now going into some specific ACT strategies, the first part of ACT is called creative hopelessness or confronting the system. And the main idea here is really to emphasize what the client has been trying, what that has cost them, and where it's gotten them. Essentially, a lot of clients come in with these hopeless agendas of trying to get rid of their symptoms. So the therapist really has to start by getting the individual open to the idea of trying something new because the previous strategies have failed, or why else would they be with you in that moment? Mm-hmm. Additionally, in ACT, control is conceptualized as the problem. And as I noted earlier, we can often amplify our own suffering by trying to suppress or control our thoughts and feelings. So ACT really encourages clients to kind of drop the struggle with themselves and with their thoughts. Then we get into cognitive diffusion, which Hunter talked about a little bit. And again, this is the process of distancing yourself from your thoughts. Just observe them as they occur without placing like a value judgment on them. One specific strategy is instead of saying, I am anxious, you should say, I'm having the thought that I'm anxious. So again, it kind of puts that barrier in between you and your thoughts. Then relatedly is the idea of transcendent sense of self, which kind of gets into this like meta-consciousness, more of those Eastern philosophical roots of ACT. But the main idea is to teach clients that feelings, emotions, thoughts, current circumstances, these are all really transient experiences. And there is this sense of you-ness that exists underlying all of those things. Then we get into acceptance and commitment. And of course, these are important to ACT. They're part of the name. Acceptance is more about being mindful, embracing the here and now, experiencing life again without that inner dialogue with yourself. And commitment, on the other hand, is more about behavioral change. So it's about strategies of moving through those psychological barriers, those negative thoughts and emotions to achieve life according to those values that you've identified. So we can see how these two are a little bit different, yet they still complement each other. The hexaflex, again, I put it on the right hand of the slide, is actually structured to include these kind of 2 halves. As you can see, I've put a line through the middle. On the upper left-hand side, this is more acceptance processes. And then on the lower right-hand side, these are more commitment strategies, so more about behavior. Of course, they still come together to promote that core goal of psychological flexibility. Just a quick note before moving on here. Of course, ACT therapists are like aware and well-versed in these strategies and ideas, but in session, they typically aren't saying like, we're in the creative hopelessness phase, you know, that's just not really accessible to people. And so the content is definitely made more relatable with more clear language and examples. So now I just want to illustrate some general differences between CBT, a common second wave therapy, and ACT, a common third wave therapy. And for the rest of the presentation, I'll be using these 2 to compare and contrast because these are the 2 that have kind of gained the most traction in the field. So first are theory-based differences. CBT believes that distressing behaviors and thoughts and emotions come from kind of irrational beliefs and really negative automatic thoughts. So we have these distressing thoughts or beliefs that we just can't really shake. And then at the heart of ACT, again, is kind of this psychological inflexibility perspective in which we're kind of tangled up with our thoughts and wrestling with them and engaging in a lot of behavioral and emotional avoidance. These theoretical beliefs then kind of trickle into their ideas about therapy itself. CBT therapists often target those thoughts and emotions directly, and they try to modify them when they're irrational. On the other hand, ACT uses more indirect strategies, again, like identifying values, acceptance, commitment, which don't target those private thoughts directly. Then CBT has proposed mechanisms that are about actual cognitive change. For example, you change the form or the frequency of those distressing thoughts. So typically, if you had like a negative thought, you'd want to decrease the frequency. ACT, on the other hand, proposes that the real mechanism is not about changing the content or the thought directly. It's more about changing our relationship to those thoughts or emotions. And then finally, health is conceptualized a little bit differently between the two. While CBT has these goals of being symptom-free, people don't want to have anxiety symptoms anymore, the goals of ACT are more about living a valued life, regardless of the existence of symptoms. Just a note, though, a possible byproduct of living a valued life, according to ACT, is a reduction in symptoms. So there is some overlap there. So now I'll be going through a more concrete application of generalized anxiety disorder. Again, I'll be using ACT and CBT to kind of illustrate key differences. So first we have overarching ideas about therapy. So both believe that with GAD, avoidance is a maintaining or causal factor. For example, someone with GAD might have the thought, nobody likes me, and then they'll avoid social situations. In CBT, they're going to want to teach new ways of responding to replace those avoidance behaviors. For example, they might teach the client, go to the social situation and think about all the things that contradict that belief that no one likes you. Maybe the fact that you got invited at all. However, ACT says that going from one fixed response to another isn't the most adaptable and flexible approach. Instead, the therapists are going to teach the client behaviors that kind of promote connection with the current environment. So some of those mindfulness things. They really want the clients to kind of experience the moment and respond based on what the environment's telling them. So another important difference is the role of the therapist. In CBT, the therapist's role is more like a coach. So they have the playbook, you're following along. Oftentimes their role can be kind of like guiding you to what's true or rational. For example, they might guide the client to realize that the thought, no one likes me, is pretty unreasonable and not based in like real truth of the situation. In ACT, however, the therapist and the client are said to be swimming in the same stream, so to speak, because the principles of therapy are supposed to be relevant to both parties. For example, if you're teaching the client that thought content doesn't have a literal truth, and then you start arguing that the thought no one likes me is irrational, you're really not demonstrating those properties that you're proposing, which can kind of derail the therapy. So next we have the role of private events. Of course, both thoughts and emotions are important to both therapies. In CBT, again, there's more direct. You want to change the private events themselves. For example, someone with GAD might have a thought, everyone's looking at me, and CBT would want to target that thought directly, maybe by decreasing the frequency. In ACT, however, you want to change the relationship to that thought. So again, the thought, everyone's looking at me, it's just a thought. It doesn't have to change your behavior in the current moment. Then getting into perspectives on goals for behavioral strategies. Both advocate for approach strategies, which again makes sense because both suggest that behavioral avoidance is kind of a maintaining factor of worry and anxiety. However, in CBT, the goal is to get rid of those automatic symptoms. For example, in exposure therapy, as Hunter mentioned, it's used for like extinction of those somatic symptoms like a racing heart. And then on the other hand, ACT uses these approach strategies to show the client that you can engage in valued living and valued behaviors even in the presence of these symptoms. For example, you can still go out even if your heart's racing and you're thinking no one likes me. And then finally, these two therapies have different techniques to achieve the goals. There's a bunch, but I'll just kind of cover one main one in each. A common one in CBT is Socratic questioning, and this is when the therapist asks you, okay, you believe no one likes you. What's the evidence for this thought? What's the evidence against this thought? Are you misinterpreting any pieces of evidence? And so on. So it's kind of like a dialogue with the client. On the other hand, a common ACT strategy is the use of metaphors, which are less direct and less about that thought content. There are so many ACT metaphors to choose from that Hunter and I kind of decided to each just pick one that resonated with us and go from there.
All right, so I'm going to talk about the person in the hammer metaphor. I love this one, and this gets at the creative hopelessness concept that Lauren was talking about in ACT, which is to help somebody realize or come to this understanding that everything I've been trying hasn't really been working that well, so maybe it's okay to try something different or just to let go in general. So, for example, let's use substance abuse. This is a great one because people in this field try all sorts of things to bring their substance abuse under control, okay? They're trying to control it. This could be like, oh, I'm just gonna use on the weekends. I'm only gonna use on a Friday. I might go to cognitive therapy, CBT for a little bit. And these things might work a little bit in the short term, but they end up in therapy again, right? And so an ACT therapist would say, every time you try this, it sounds like, you know, it might work a little bit, but it's kind of like hitting yourself in the head with a hammer. It doesn't quite get you to where you want to go. Every time you try to control your substance use and these thoughts that come along with it by deep breathing, by using on certain days or over the weekend or trying this type of therapy, look at where we're at. We're in therapy again. So it kind of gets this idea to help them see that everything I've been trying in the past to control my behavior is just not working. Creative hopelessness. And then this opens up sort of like this idea that I've been trying to control this for so much, and maybe it's okay to try a different, less direct strategy. And so now I'm going to turn it over to Lauren to do the beach ball metaphor.
Yeah, this is one that is one of my favorites because it's really easy to visualize. We've all been here, but imagine you're swimming in a large swimming pool. And while you're swimming, you notice this like ugly beach ball and you don't want it anywhere near you. So you begin to push the beach ball down underwater, but it pops back up to the surface. So you push it down even further and even harder, but it pops back up with even more force. So this continues for several minutes until you kind of realize that struggling with this beach ball is not getting you anywhere. It's so futile and it's so draining. So another option is just let go of the ball, let it float around you. Eventually the ball will probably float to the edge of the pool far away from you. And we can kind of think about our emotions as the beach ball. The more we struggle with it, the more we're drained and we're just still not getting anywhere. So another strategy is to let them go. So as you can see, these metaphors are very indirect, but they can definitely be more understandable and digestible to clients. And we kind of wanted to end with this quote. It's by a comedian, but Steve Hayes, one of the founders of ACT, uses it to kind of explain diffusion and mindfulness. It says, I used to think my mind was my most important organ until I realized what was telling me that. And so when you think about it, all of our organs tell us something. Our stomach tells us we're full. Our skin tells us when something's too hot. But our brain is the one that actually uses human language. And it's often the organ we listen to the most, even when other parts of our body are telling us something different. So it really, really gets at the power of language and the importance of listening to your whole body. Listen to all your experiences. Don't just listen to the part of your body that's talking to you all day.
And that takes us to the end of our webinar on behavior therapies. And so wonderful job describing that, Lauren. Appreciate that. So I guess now we're going to leave it open for some questions and answers for anybody that has anything that they'd like clarified.
Thank you, Lauren and Hunter. Just to echo what Hunter said, if you have any questions you would like them to answer now, please feel free to type it in the chat box. Or if you're feeling brave, feel free to just jump right in and ask.
I don't really have any questions, but I want to say thank you to Lauren and Hunter for a great presentation. It was really nice to hear. I think just like personally, I'm so behavior focused, so it was nice to learn from y'all, and super digestible. So I think that was great. So thank you for your time and the presentation.
Yeah,
it's a ton of information, so thanks for hanging in there with us, and hopefully you can pick out some pieces that were helpful to you.
we have a number of resources. This literature gets very dense and you can easily go down rabbit holes. And so we tried to depict it as easily and digestible as possible. But if you would like some of those resources, please feel free to email us. A lot of them were written by Hayes and Linehan and other people who are, real big proponents of third wave therapies as well. So feel free to reach out. Well, I have a question for y'all. Are y'all aware that there were waves of behavior therapy? I know CBT and ACT come a lot and exposure, but were y'all aware that there was like these designated waves of behavior therapy and how they came about? Not a lot of people do, and I was just curious.
I don't know like the full history about it, but working in an inpatient setting, I mean, we're exposed to DBT and different like mindfulness types of therapy as well. So, I mean, I have a little bit of background on it. I mean, I was certified in DBT like 4 years ago. I still don't have that certification, but it's interesting hearing how you guys compare it to everything else. It was a really great perspective.
Appreciate that, Victoria. Thanks for the feedback. Hopefully you'll get that DBT certification soon. That'd be nice to have on the CV.
Victoria is coming from a clinical perspective as we are too, so.
Yeah, yep.
That could be it.
I think it's I love to see how the waves kind of connected to each other and how how everything's kind of connected. When I learned about ACT first, I did not know about that connection. And then I remember, Hunter, you talking about this, and then I did some research and I learned. So I think in this presentation it was awesome to just kind of see how everything came together. So it was great. It makes me think about what would be next, like if there's anything, because it seems already that's so good now, and I'm just wondering what would be next, like what they would add, if they will add anything.
Hunter, you're on mute.
Oh, there we go. Thank you. I thought about that same thing earlier today, like what would a fourth wave even look like? And so if we look back at second wave and how long that lasted, that lasted quite a while. And the evidence base for it was really strong. There was just these things that people thought could be tweaked a little bit. And the change was actually ended up being pretty big. So I think that if I had to put money on it, we'd be in this way for quite a while, because we still have a lot of work to do in terms of really scrutinizing ACT and these third wave therapies and figuring out the mechanism of change and really building this strong evidence base for these third wave therapies, similar to cognitive behavior therapy. That's very big. I mean, that's been around for a long time. And I also want to convey this idea that I don't think any wave is particularly better than the other. Like, I think it depends on the individual, right? And so somebody might hate metaphors, and so they probably wouldn't benefit from third wave therapies, right? And so their mind and how they work might appreciate those more targeted change-based strategies that we see in second wave and things like that. So I wouldn't say one's better than the other. I'm not trying to advocate or advertise one over the other as well. It comes down to individual differences because, well, it's individual therapy, right? And so it's always good to take it from that perspective. So just wanted to make sure I conveyed that too. But thanks, Jana, for that feedback. I remember having that conversation about a year ago. I'm glad you took it upon yourself to sort of dig in the literature too. So thank you.
I have a question. I guess it's more just like your thoughts on it. So in this third wave of behavior therapies, we see a lot more of the mindfulness side of things. And there's this huge push these days. You see this trend of mindfulness and like formal practices of mindfulness and like sitting down for 15 minutes and meditating. What are your thoughts on like formal practices of mindfulness, the usefulness of that versus just bringing mindfulness to the reactions that you have to your thoughts and your behaviors, kind of what you touched on. Was that clear? The question?
Lauren, you want to take that or?
Yeah, I think definitely it can be kind of something separate. It is like the separate piece of all the therapies that I think it's okay to have it be its own thing. And you can also incorporate it into like CBT. You know, I feel like it's very much its own thing that can be applied in different ways to all the therapies. So like ACT has a little bit of mindfulness, DBT does. And yeah, that's kind of my perspective on it. I think it's definitely something that therapies are trying to incorporate, but can also just be like this separate thing.
Yeah, and I think it could go both ways too. It can be a reactive strategy and it can be a proactive strategy, right? So you're just doing this on a daily basis, and then if something comes up, I'm going to try and diffuse myself from these thoughts. I'm going to step back a little bit, and you know, you kind of exercise that repertoire as you use this on a proactive basis, and then when it comes up and you need to use it, you kind of have it there. And so that's kind of how I see that, and that's how I use it in my life too. I've really been trying to practice this a lot of mindfulness lately, and it's really interesting. It's oddly effective, you know, for somebody who really came out of like the CBT thing in undergrad and such. So it's worth a try for anybody who wants to try it. Different ways to do it too.
I'll throw my question out there. I come from preschool, and so we use a lot of ABA. Where does ABA fit in? It seems like it would be way back in the first wave. And I think it's because they're so young, they're still developing their language, and a lot of the SPED kiddos don't have the reasoning capability as well. So, but still, how does ABA fit in there?
So anybody feel free to correct me. You know, I think it's just applying the tenets of behavior analysis in an applied setting. And so it doesn't always look like this very rigid way of working with individuals. It gets a sort of bad rap sometimes. And so third wave therapies, if you dig into the literature, they will term it as radically behavioral because it really just gets at this idea of function of behavior. And so how does mindfulness play into that for that younger age group? Is that sort of what you're referring to, Crystal? It's a good question. And this is something that I have been asking myself too with the younger kids that I work with. To what effect is mindfulness working with these students? Because it's kind of this abstract idea to stand back and observe your thoughts and be mindful of what's going on in your body. And so I think just being creative in how we present this to them is really going to be one of the best ways I can see to help this make sense to them. And even if it doesn't make sense at first, we're having them engage in these practices. And it's not something that they just forget all of a sudden. They just have another tool in their toolbox as they're growing up. And then they can find out which ones tend to work best for them or not. And as they get to this point where they engage in this abstract reasoning, where they can sort of take a look at their thoughts and, you know, kind of get into that more meta idea, I think then at that point, you know, having exposure to mindfulness activities, to change-based CBT activities or strategies can kind of just give them a really nice toolbox to figure out which one works best for them. They might find that changing their thought in one situation and being diffused in another situation might work well for them. Kind of gets at integrative therapy. I think one thing that if you are a therapist, peppering in both of those could promote contradictory ideas of acceptance versus I need to change what I'm thinking or what I'm doing. Back to your question, I think I do mindfulness. I do the raisin, experiment with them, help them deep breathe and notice like what's going on, what's their experience telling them versus what their brain's telling them. And it's worked well. Preschool is younger. I'm talking maybe more around like, primary, like 3rd, 4th, 5th grade or so. And they seem to like it pretty well. I think just walking them through the experience and letting them, take from it what they can is really the best we can do. It's sort of that age. It's really tough. And so hopefully as third wave continues to be researched, we'll find that it's, what ways can we deliver it to really young age groups? It's still an emerging therapy. Like we're still trying to get all these randomized control trials up to show like this is really working. I think later on, hopefully, we'll tailor it to very young populations like preschool as well. Hopefully we'll see some similar outcomes too. I wish I had a more concise answer to that one, but maybe somebody else does. But if not, you can feel free to email me and I'll provide you with any sort of resources that I do have.
And just like touching on like where ABA fits in, ACT is based in RFT, relational frame therapy, and there are like a lot of ABA curriculums that specifically like teach kids with autism and younger kids kind of like principles of RFT and like how to relate things. So I think, although they're different and can be applied differently, there is some overlap, especially with like the language component of things.
Yeah, I forgot about relational frame theory. That's like the whole behavioral theory of language and cognition. That's a really big piece. I didn't put that into the presentation because that's just like a whole nother topic there. But if you want to look into it more yourself, RFT, relational frame theory, can provide you with some more guidance on how this might work at younger age groups and how people learn to relate to their environment.
If there are no other last minute questions, we're going to go ahead and wrap up. So this will conclude our webinar for today. Thank you everybody so much for joining. This session is recorded and will be published onto the U-TTEC Lab website, which you can access by just putting in U-TTEC-lab.com. And if you go there, you will see all of our past webinars also published there as well. Feel free to check in with the U-TTEC Lab social media handles to get the most up-to-date information about us. Our next webinar will be on October 30th, so stay tuned for that. And yeah, thank you again, everybody, so much, and great job, Hunter and Lauren.
Thank you everybody for attending. I hope that you can take some stuff away from this and maybe apply it in your practice. And if not, maybe you just got some more information in your brain. Hopefully that's good enough sometimes, right? So thank y'all.
Thanks everyone.